Chapter 29 here, trauma to the head, neck, and spine. So the nervous system controls thought, sensations, and motor functions. Central nervous system, as we've covered before, brain and spinal cord. Peripheral nervous system, your vertebrae nerves, cranial nerves, body's motor and sensory nerves. Little diagram of the nervous system. It's in your book if you want a closer look at it. The head, you have your cranium, facial bones, there's 14 of them, the mandible, maxillae, nasal bones, zygomatic, the malar, the orbits. Okay. Spinal cord exits base of brain and leaves skull through the foramen magnum. It's a hole in the base of your skull. That's a good one to know for test purposes. I saw it on the state test. I saw it on my paramedic test. It's a good one to know. Cerebral spinal fluid, CSF, bathes the brain and circulates down the spine. Another diagram of the head, all the bones and structures of it. Again, if you know all these bones, great. If not, it's really not that big of a deal. The mandible is something that you will come across often, as well as the orbit. But the rest of it, not so much. The spine. You got vertebrae. Cervical, you have 7 of them there. They are classified as C1 through C7. Thoracic, there's 12. T1 through T12. Lumbar, there's 5. You get how they're labeled. Sacral, coccyx. Each has a spinous process. So you can see here the vertebrae going down through where they're located. Cervical is obviously neck, thoracic. It's in your thoracic cavity. Lumbar is the lower back, sacrum, and then your coccyx right there at the bottom. Injuries to the skull and the brain. You'll come across a lot of scalp injuries, especially from falls or blunt trauma. There's lots of blood vessels. If you've ever seen somebody with a scalp injury, there's a lot of blood. They bleed very quickly, profuse bleeding. Skull injuries, either open or closed, depending on if the skull is affected. So here's an open skull fracture, okay? Obviously, that's a very distracting injury. You're going to pay very close attention to this patient, monitor their vitals frequently. You're going to look for changes in mental status, etc. Okay? But don't let this distract you from other things that may be going on with the patient. So brain injuries. You can have direct injuries. The brain is lacerated, punctured, or bruised by broken bones or by a foreign object. Indirect injuries. The shock of impact on the skull is transferred to the brain and include concussions and contusions. Alright? So know the difference between those two. Now the direct injuries, it's the laceration of the brain. It's going to be from something piercing the skull and going into there. I've cared for gunshot wounds to the head before, in which the brain is obviously affected. They were dead and didn't even know it at the time. They were still barely breathing on their own at that point. There's nothing you can do except for keep the body perfused enough to hopefully harvest organs if they're an organ donor. TBIs, traumatic brain injuries, an injury that disrupts the normal functioning of the brain. Can be a concussion, maybe so mild patient is unaware of the injury. You see these a lot in football and sports. A contusion, coup, or a contre-coup. So the concussion, right? So you're going to get blunt force trauma to the head, right? Now the brain is protected by the fluid in there, right? But it can still move in there. You get enough blunt force trauma, the brain will actually come into contact with the skull, which causes the injury. You can have lacerations, hematomas, subdural, epidural, or intracerebral, depending on what part is affected. So diagram showing the differences here, the dura, epidural, subdural, intracerebral. Okay, intracerebral is within the brain. Epidural is on the outside there. You can see it's between the skin and the actual skull. Subdural is underneath. Patient care. As always, as we've talked about before, standard precautions. You're going to have your gloves on, right? Go and check your ABCs. Consider possibility of a spinal injury. Anytime there's an injury to the head, spine, you need to, have a high level of suspicion of that. Open and maintain the airway. Monitor an unconscious patient for changes in breathing. Okay, any injury to the brain, which controls everything in the body, you want to make sure that their breathing is appropriate. ABCs, as always, you're going to keep reassessing that throughout the call. If indicated, apply a C collar. Control any bleeding. Keep patient at rest. Talk to a conscious patient and provide emotional support. Injury like that, they're going to be pretty worked up, right? You need to reassure the patient and let them know what's going on. Dress and bandage open wounds. Stabilize penetrating objects, just like any other trauma. Manage patient for shock. Be prepared for vomiting. A lot of head injuries are going to be very nauseous. You need to be aware of that. Protect their airway. Transport patient promptly. And vital signs every 5 minutes. Intracranial pressure. When a hematoma develops and pressure increases inside the skull. As the pressure builds up, it compresses the brain tissues, and progressive neurological abnormalities develop. Depending on what part of the brain is being affected by the pressure and being compressed, will determine on what abnormalities you may see. The time it takes for symptoms to develop depends on the rate of bleeding. Okay, so if it's a rapid bleed, a very large bleed, it's going to be very quickly. We've seen patients before, they've had a head injury, whether they seek treatment or not, they may have a slow bleed, and the symptoms will develop days later at times. As you guys remember the patient that I had right after Thanksgiving that flipped her car end over end? She died of a head bleed, okay? And it was 2 days before it developed enough to compromise her life. So symptoms: rising blood pressure and slowing of the heart rate, together known as Cushing reflex. That's a good one to know. Rising blood pressure and the slowing of the heart rate. They're going to be altered, dilated pupils, or sluggish pupil reaction. They can have the Cheyenne-Stokes breathing, central neurogenic hyperventilation, ataxic respirations, decorticate or decerebrate posturing with herniation. Right. The best way for me to remember the difference between these two, okay, decorticate, it's got the word core in it. So their arms and everything will come into the core, their body, right? So it's going to be posturing with their hands and everything in towards their body. Decerebrate is going to be out, away from their body. And that's how I remember that. If you guys have a better way, let me know. Maybe immediate or delayed in onset. So does my patient have a serious or potentially serious head injury? Should the patient be transported to a trauma center? I mean, you're going to be looking at the mechanism of injury. You're going to look how they're presenting to you. Do my patient's complaint and MOI indicate spinal stabilization? Is immobilization warranted? Now, things are rapidly changing in the EMS here. Okay, it used to be, even when I first started, by God, everybody got a collar, everybody was put on a backboard. It's been proven now that that can actually cause more damage than anything. So what we do now is a C-spine clearance procedure. And everybody's protocols are a little bit different in regards to that. So once you get out on the street, follow your protocols in regards to that. I rarely will backboard a patient anymore. If they're on a backboard, it's typically just for moving purposes. but I will put people in collar still. Alright, cranial injuries with impaled objects. Again, what do we do with impaled objects? We stabilize it in place, right? It's the same regardless of where it's at, whether it's in the head, whether it's in the abdomen, chest, leg. You're going to stabilize it in place. You're not going to pull it out. Cutting a lengthy impaled object should be done with a tool that will not cause object to move or vibrate when it is finally severed. That's fire department job right there, not your guys's. You're going to get fire on scene, and they'll use what tools they have to shorten the object. Injuries to the face and jaw. Primary concern, right? ABCs. You're looking at the airway. It can cause a lot of bleeding. It can, be an obstruction. You wanna watch for that. When possible, position to allow for drainage from the mouth. You don't want the blood building up in there and them swallowing it or aspirating. Non-traumatic brain injuries. Many signs of brain injury may be caused by an internal brain event, hemorrhage, blood clot, strokes, right? Signs are the same as for a traumatic injury, except no evidence of trauma and no mechanism of injury. They're going to be altered, right? Their blood pressure is going to go up. Heart rate is probably going to go down. There's going to be pressure in there. There's going to be effects. Think about with a stroke, okay? A hemorrhagic stroke, putting pressure on the brain. They're going to prevent with the deficits. All right, GCS. It's the Glasgow Coma Scale and AVPU for neurological assessment. You're going to obtain the GCS on every single patient that you encounter, okay? So what you're looking for is eye-opening, okay? That's the first one. It's based on a scale of 1 to 5, right? Or, let me think here. No, 1 to 4 on the first one, I'm sorry. 1 to 4. So are they alert? Yeah, so they get a 4. Are they alert to verbal? They get a 3. Pain, 2. Unresponsive, 1. Right? Then the next one is verbal response. Okay, are they oriented, confused, inappropriate words? Incomprehensible sounds. These are the people that are like grunting, okay, or they can't form the words properly. And then the last one is absolutely no verbal response. So on that one, it's going to be either a 1, 2, 3, 4, 5. A 5 is oriented. They can talk normally. Confused, 4. Motor response. This is on a 1 to 6 scale. Obeys commands, and that's a 6. Localizes pain. Okay, so they know where the pain's at, and it can tell you. Withdraws after painful stimulation. Okay, they're not really able to tell you what's going on, move around very much, but they will move away from the pain, whether you do external rub, whatever. Posturing after painful stimulation, and then no motor response to pain. Don't spend time at the scene calculating the GCS score, okay? It's not highly important. You're going to figure it out on every patient, but it's not your top priority. So wounds to the neck. Got large arteries and veins close to the surface, creating the potential for serious bleeding. Pressure in large vein is lower than atmospheric pressure. Great possibility of an air emboli being sucked through. Pulmonary embolism, PE. Treatment, stop the bleed. Prevent air embolism, inclusive dressing, right? So, patient care, as always, ABCs. Ensure open airway. Place gloved hand over the wound, okay? Just like with a penetrating chest trauma. Gloved hand. Then apply your occlusive dressing. Place dressing over the occlusive dressing. And just make sure the air still has room to escape if that's an issue. Apply pressure to stop the bleeding. Bandage dressing in place. Immobilize spine. The mechanism of injury suggests cervical injury. Injuries to the spine. Assume possible cervical spine injury based upon the mechanism of injury, right? Depending on what's going on, high falls, sometimes geriatric patients, just a ground level fall, you will suspect it. Did they hit their head or anything on the way down? Was that a vehicle accident, at a high rate of speed? The spinal cord is a relay between the body and the brain. Risk of primary and secondary injuries just from an injury in the spine. So you see here a little diagram, diving injuries, spinal injuries are very common with that. Car accidents, you have your impact with the windshield, you got the up and over response there. Being rear-ended, you have a lot of whiplash, your head snaps back when being rear-ended. Identify potential spine and spinal cord injuries. Potentially devastating consequences. Depending on what vertebrae are affected, will determine what symptoms the patient may have. Okay, your C1, C2, C3, those are essential, especially C1 and C2. You fracture those, a lot of times you're just going to die. There's no coming back from that. That affects all your nerves, breathing, respiratory, all that. Okay. Now, I have had a patient, he did fracture his C1 and C2. He was also the guy with multiple tib-fib fractures, to where the bottom of his leg was like rubber. He lived. He lived. He was discharged from the hospital about a week and a half later. Actually went back to him for extreme pain, but yeah, he should have died that day. Absolutely. So assess mechanism of injury. Keep a high level of suspicion. Physical condition of the patient. So high risk, falls from greater than 1 meter, roughly 3 feet, or down more than 5 stairs. Axial loading, compression injuries, those are your diving injuries when you're landing on your head. High speed MVCs, especially with rollover or ejection of the patient. If you have a death in the same vehicle, suspect multiple injuries with your patient. Energy that forces movement of the spine beyond its normal range of motion. You will have football injuries where bodies are bent backwards. You've all seen the videos, I'm sure. Whiplash, especially from rear end accidents. It's just forcing your head to move backwards and snaps that neck. Affected by certain medical conditions, osteoporosis, degenerative diseases, all that affects it. High risk, ATV crashes are a big one. Obviously, the patient is not restrained. Most people don't wear a helmet. There's a lot of injuries that way. Bicycle collisions, especially with another vehicle. Maintain a high degree of suspicion if a vehicle was involved. Many other mechanisms of injury can cause spinal injuries. Even just simple things, ground level falls, like I said, especially with geriatric patients, can cause spinal injuries. Pain and tenderness are important findings. Doesn't necessarily mean that you'll always have that. Dermatome, area of the body surface inverted by a single spinal nerve, can be used to identify loss of function. Paralysis of extremities, good indication obviously. Changes in neurological function, you're looking for that pulse motor sensation, if they can't wiggle their toes, good indication. Pain with or without movement. Tenderness anywhere along midline spine, or impaired breathing, especially if it's the C1 and C2. I did have a patient one time, she wrecked her car, low mechanism of injury, would have never suspected. She said her back kind of hurt a little bit, not a whole lot, She'd been moving around on scene when we got there. We walked her to the ambulance. Didn't put her on a board, didn't collar her. She was moving around just fine. She ended up having multiple spinal fractures. Ended up being a very serious call. Not while we had her. Everything checked out great, but always have a high level of suspicion. Priapism. It's for the dudes out there. They're going to have that erection going on. indication of a spinal injury. Loss of bowel or bladder control, very common. Deformities, not so common. You may not always see that deformity on the back or during palpation, feel it. Neurogenic shock. Geriatrics, keep in mind that fractured spines in older adults are often caused by falls or spontaneous fractures of brittle bones that in turn cause falls. It can happen. I've personally not had to deal with a spontaneous fracture, but it does happen. Their bones are just brittle, they're breaking down. Alright, so assess your ABCs. That should be the top one, as always. Provide manual inline stabilization if you suspect a spinal or neck injury. Assess head, neck, and apply rigid cervical collar. Assess for your PMS, sensory and motor function. Apply appropriate spinal immobilization device. It's typically your long spine board with straps. And then you're going to reassess your PMS. Alright, spinal immobilization. Even low-risk patients used to be cared for as though they had a spinal injury. This is the way of the past. Once taught that the most important care was restricting patient movement. Secondary injury, now known to be caused by hypoxia, shock, and hypoglycemia. Spinal motion restriction is modern terminology for it. Remember that the spine is anatomically curved. So think about that. If it's normally curved, we're putting patients on a long spine board that is flat. What do you think we're actually doing to the patient? Cause more injury, right? So spinal motion restriction. It's one of the first steps. Manually restrict head movement by placing your hands on either side of the patient's head. You're going to hold it in place, prevent them from moving their head. Collars need to be properly sized. You have your peds, you have your adults, you have your no necks. There's different sizes out there. And if the seat collars that you guys use don't properly fit, you can use a horse collar, which is rolling up a blanket. We'll teach you guys all of that too. Okay, do what you have to. Use in conjunction with another immobilization device. Okay, so no collar completely eliminates movement in the spine. It just doesn't work that way. And although backboards remain useful, the ambulance stretcher provides appropriate spinal protection. Okay, think about that. It provides protection for the spine. The long spine board is a thing of the past. For most EMS systems, the rigid spine board is still commonly used though. Follow your local protocols. Again, I'm a big believer protocols are a guideline. So yeah, do as you please on that one. But it's your license. If you want to follow protocol strictly, do so. Vacuum mattresses are great. They're a great tool to have. I highly recommend them for every service. It just pads all the voids, keeps a patient in a neutral position. They are just great. They take a little bit more time to get set up, but I highly recommend them. Uncertain whether rigid device is necessary in non-moving situations. Alright, so there you can see one of them is holding manual C-spine there. The other one is applying the collar. So patients who may have been subject to spinal injury are found in many different positions. By God, you will find them in every position possible. Whether it's in a vehicle or stuck between the toilet and the shower. Good God, any position that they will be there. Be sure of the sizing and application prior to implementing the procedure. For an infant or a child, use a ped size collar. If you don't have the right ped size, use a rolled towel. You can do that on an adult as well. Maintaining manual support of the infant's or child's head. Low priority, use a short board or a vest immobilization device. Every ambulance will have these. I'll be honest, I've never even used them in my career. High priority, maintain manual stabilization while moving the patient. So you have vest-style extrication devices. Yeah, I mean, they're great to use. They have their place. Again, I've never done it. I feel personally that we can do the same thing with the collar, manual C-spine, and a long spine board to get a patient out. You have short spine boards just for the upper torso. Sequence to follow: torso first, head last. Always make sure you assess the back, shoulder blades, arms, and collarbones. Must be done before the device is placed against the patient. This is for any device, okay? You want to check their back and everything. Anything that you're going to cover permanently with whatever device you're using, you want to assess that area first. The EMT applying the board must angle it without striking or jarring to fit between the arms of the rescuer, who is stabilizing the head from behind the patient. Bit of a pain in the ass to do, to be honest. Provide full cervical support. The uppermost holes must be level with the patient's shoulders. The base of the board should not extend past the coccyx. Never place a chin cup or chin strap on the patient, as it can prevent him from opening his mouth if he has to vomit. There are some collars out there that actually go around that way, so just always be careful depending on what your service uses. Avoid applying the first torso strap too tightly. Some buckles have quick release mechanisms. Do not pad between the collar and the board. A lot of people do. This will create a pivot point that may cause the cervical spine to hyperextend when the head is secured. Never use excessive padding behind the head. Follow the instructions provided by the manufacturer of the device you are using. It's a good cover your ass right there. Follow the instructions, right? Follow. So there's they're holding C-spine still. The collar is not enough until they're secured to a board or a extrication device. So applying a long backboard. Log roll the patient. Pad voids between board, head, and torso. Secure the head last. If they're pregnant, you want to tilt the board to the left after immobilizing. Simply put a pillow underneath the long spine board will do that. Strap across chest, pelvis, and thighs. Peds. When immobilizing a 6-year-old or younger child, provide padding beneath the shoulder blades. Remember, they're anatomically to keep the airway open. You need to pad underneath the shoulder blades, right? Because of the head. Practice immobilizing children using adult equipment and lots of padding. Immobilizing a child in the child safety seat is no longer recommended because the integrity of a safety seat may have been compromised in the collision. Yeah. Honestly, this is something we still do. If they're in their car seat, we're not concerned about their airway or anything like that. We will pad around them and leave them in the car seat. What they're talking about is when a car seat has been in a motor vehicle accident, it can deteriorate, be compromised, there can be defects, cracks, whatever. So the thought process is going to the hospital. If you were to get in another accident, it can put the patient at risk. However, if we don't feel there's anything that we need to do for the patient as far as protecting airway or whatever, we just leave them in it. And that's the street way of doing it. So with a standing patient, you can do a rapid takedown. Requires 3 providers. Supposedly, you can do it with 2. Cervical collar and a long backboard. So what you do there is you have you place the backboard against a patient, you hold manual C-spine, and then you lower them down by placing your arm underneath their armpit there and grabbing the board from the front. Again, you can do this with 2 people. They recommend 3. As you see there, they're underneath the armpit holding the board, still holding the C-spine. Honestly, it's easier with 2 people. Alright, helmets. Something you're going to run into. Motorcycle accidents, very common, right? Leave it in place if it fits snugly and it's not allowing movement. You just pat around the helmet to secure it in place. Absolutely no impending airway or breathing issues. If you're worried about that, you remove the helmet. Removal will cause further injury. Proper spinal immobilization can be done with a helmet in place. It doesn't interfere with the EMT's ability to assess airway or breathing. A lot of the motorcycle helmets now, the entire front part of it, there's a release mechanism to where it will come up so you can get to the airway. If it interferes with the EMT's ability to assess and manage airway, take it off. If it's not fitted properly, they need to be snug, right? If it interferes with immobilization or in a cardiac arrest. So some critical thinking here. You're treating a patient with a head injury as an altered mental status and significant MOI to the head. Your partner thinks you should hyperventilate. When should you hyperventilate? What are the signs and symptoms that would indicate this is necessary? Honestly, the only time you're going to hyperventilate a patient is if you're going to intubate them. This is out in the field, okay? You don't want to hyperventilate a patient. If it's recommended, if you're going to intubate, you do some quick hyperventilation to provide O2 because you're not going to be bagging for a while. Other than that, honestly, out on the street, do not hyperventilate. Alright?